Precision health, by its very nature, is multidisciplinary, and we are fortunate to have experts from many areas of campus right here at the University of Michigan. Our first speaker is Akbar Waljee. He's a professor in the Department of Internal Medicine at Michigan Medicine, and he serves as the faculty lead for the Data and Methods Hub and co-director of the Michigan Integrated Center for Health Analytics and Medical Prediction, or MiCHAMP. He also serves as the director of the VA CCMR Prediction Modeling Unit, and clinically, he's director of the Inflammatory Bowel Disease Clinic at the VA Health System. Dr. Waljee's presentation is on learning from strangers, AI as a tool for reciprocal innovation and impact in global health. Dr. Waljee.
Thanks, everyone. It's great to see everyone here. I have to admit, I'd be lying if I said that I wasn't on edge. This is completely new and different, and it seems like this is the first presentation that's been in this hall in over 2 years. But again, thank you for those joining in by web and for everybody else here today. So my talk is again entitled Learning from Strangers. AI is a tool for reciprocal innovation and impact in global health. And just to give you a layout of the format of the talk, the goals are to give you some definitions around artificial intelligence, machine learning, data science, more so to just make sure we're all on the same page about those terms. Walk you through a prediction model that we developed at the national level. And really, I'm very cognizant of Dr. Watcher's talk, and I want to try and address some of the comments that he brought up during his talk too. Try to think about ways we should be leveraging data in the global health setting. We seem so reliant on EHR data, but there are other ways to use the data more globally. And then briefly talk about some of the collaborative efforts that are going on campus, which is where I think the strengths are at the University of Michigan. So the challenge is that data is coming at us like a tsunami. It's often known as a data deluge, especially in health. And we struggle in how to deal with this data. And can we use artificial intelligence and machine learning as an example of teasing out sort of that signal from that noise? Now, big data, in its true definition or a technical definition, is when extremely large data sets that may be analyzed computationally to reveal patterns, trends, and associations, especially relating to human behavior and interactions. And that's one of the definitions from the Oxford Dictionary. But from an experiential standpoint, data is all around us. We see it in our daily lives, with the interactions with the world. But it's this natural result of us collecting data on ourselves. And it's this digital exhaust of the day-to-day interactions that we have that we're trying to capitalize on to better understand the world around us. What is artificial intelligence? Artificial intelligence is when a computer does tasks that normally requires human intelligence and discernment. It focuses on 3 key skills: learning, reasoning, and self-correction. And machine learning is an AI subfield using statistics to help computers learn from experiences. Now, Dr. Domingos from the University of Washington, the analogy he uses that, in traditional programming, we would traditionally give a computer the data and then we would program it, right? We would use languages like BASIC or C++, and that would be quite time consuming, but ultimately you'd have an output. And maybe the output in health would be disease or no disease. But when we think about artificial intelligence, we're giving the computer the data and the output, that outcome. And we're letting the computer identify those patterns or those trends and ultimately develop a program or an algorithm or a classification. And we're really letting the data do the work here. Now, we've acknowledged that there are a number of different limitations and hurdles, but I'll just talk about 3 of them. It's really important to identify what is the question that we're trying to address, right? It's not about comparing drug A to drug B, but really trying to say, okay, how do we automate driving around campus in a certain environment? The methods matter, right? It's just not about data wrangling and just trying to identify results as a part of analysis, but really thinking about generalizability, reproducibility, the ethical, legal, social implications of the data. And we talked briefly about that earlier. And then lastly, teams matter. This is not an individual process. It's really trying to bring experts together, including those that you're disseminating to, and involving them early in the process. But from a methodological standpoint, I've had a long-time collaborator from LSA, Dr. Zhu, and his grad students who have really been engaged and involved in how to try to develop better methods to answer complex solutions. And then, more importantly, is that these teams exist across campus. And I just want to highlight a few of those teams. MIDAS, the Michigan Institute for Data Science, and Jing is here today, so if anybody wants to talk to her more. But this is a data science institute across campus, not only in health, that can facilitate collaborations amongst us. The Michigan Integrated Center for Health Analytics and Medical Prediction, a group that comes together every Fridays, domain experts in health and methodological approaches to try and see how can we advance all those new approaches to try to deliver optimal care using artificial intelligence and machine learning. We talked a little bit about precision health, around the discovery, treatments in health. And then I'll tell you a little bit more about Ehail, which is e-health and artificial intelligence, which is another ongoing initiative here at the University of Michigan. Now, again, we've talked about some of the real-world applications and why they do that. They have large digital data sets with known outcomes, and they're trying to identify these patterns to predict the future, whether it's on clicking on advertisements, purchasing of items, signing up for promotions, switching cell phone providers, identifying what you want to watch on Netflix, and all these commercial sectors are really trying to optimize the use of this data for their own purpose, and generally money, but yes, for their own purpose. But I wanted to maybe talk to you a little bit about how we could use this in our healthcare setting. And I'll walk you through a prediction model that we developed in the VA, and then talk a little bit about how could we leverage this more in the global context. So from a national standpoint, the VA is a place where we develop complex patient-centered population health programs for various diseases. And in this particular example, I want to talk a little bit about hepatitis C. And we're trying to leverage data to deliver high-value care in these low-resource settings. And when I talk about low resources, I don't only mean financially, but there's so many different reasons why you could be low-resourced in terms of access. I think COVID-19 exemplified low resources in terms of PPE, for example, the personal protective equipment. And can we use artificial intelligence and machine learning to help optimize delivery of care and services? Now, when it comes to hepatitis C, we created two models that I'll walk you through just as an exemplar. One using a clinical trial data set, and then one using VA data. But to give you a little bit of background on hepatitis C, in 2016, there were about 250,000 veterans with hepatitis C. In the US, 3 million people with hepatitis C, and around the globe, 170 million people with hepatitis C. And when you think about the hepatitis C virus and what it does to your body, well, when hepatitis C infects your liver, either through IV drug use, blood transfusion, number of other injectable ways, this virus tends to cause a lot of inflammation in your liver, and 75% to 85% of people that are infected with this virus will ultimately develop chronic hepatitis, where there's all this inflammation going on in your liver. And as all this inflammation and healing continues to undergo transformations in your liver, you'll ultimately develop cirrhosis or scarring of your liver in about 20 to 30% of people. And then eventually, about 2 to 7% of people per year will have end-stage liver disease, or potentially complications of that end-stage liver disease that also include cancers. And so quite a devastating disease that takes years and decades to actually result in that final outcome. But for the first time ever, back in 2015 and 2016, we had some amazing drugs come out. These were some of the drugs that we actually haven't really seen in the recent past, where there was a greater than 90% efficacy rate of these drugs. But they came at a cost, right? Came at a cost of $100,000 a treatment during the 2015-2016 period. And just to give you an example of what that means, if I told you that with 250,000 veterans at $100,000 a treatment, that would be $25 billion. That would bankrupt the VA right away. And how would we propose to treat everybody within the VA, not only because of the resources financially, but because of access and providers? So could we think of more strategic ways to optimize treatment? So when we think about how AI could potentially be used in that setting, we have a population of patients that have hepatitis C, and we're trying to define those that are most likely to progress in their liver disease, maybe as one potential strategy in order to make sure we're treating the right patient with the right drug at the right time. We know that there's some rigid factors like gender, age, that we can't actually change, but they're modifiable factors, primarily around treatments, interventions, that maybe we could optimize in order to make sure that people don't have an adverse clinical outcome and compare those to those that have no clinical outcome. So in the first instance, we said, okay, well, could we develop a model using clinical trial data that sometimes is thought to be the gold standard of everything because that's more generalizable, there's more variation in the kind of data that you have there, and say, okay, well, can we use random forest, an AI machine learning methodology that has this longitudinal data in the HALT-C data set. This was the hepatitis C antiviral therapy to prevent cirrhosis data set. And in this data set, the folks that were randomized to an older generation of the hepatitis C drug that wasn't quite as effective, and then some that weren't treated at all in this randomized control therapy pathway. And we had data for 3.5 years. And so could we use that longitudinal data to make predictions around who was going to progress faster than others? And then we tried to do the right thing and externally validate that with our Michigan medicine cohort. And what we want to do is predict outcomes such as progressing of the disease, failing of your liver, liver cancers, or liver transplants-free survival. And we combine this as a composite outcome for that 1 and 3 year prediction. This is just a little bit of information about the demographics of this population. It was important to highlight this. So in the HALT-C cohort, about 1,050 patients, the Michigan medicine just over 1,000. Similar in age, majority male, and then 72%, 80% white in these respective populations. And our methodological approach was as such, that we knew that in a clinical trial that we had all these data points, and the data points here are represented in the diamond circles. And each of these data points had an associated outcome with it. So the white circular areas is those that did not have an outcome, the potential periods of times in the data point that maybe someone did have an outcome, and so on and so forth. And what we were trying to do was take these data in this geographical time period to then say to ourselves, can we predict the outcome in 1 year? Oops, going the wrong way. Or can we predict it in 3 years, using all the information from the prior years and summarizing that in a way that would allow us to then use machine learning and artificial intelligence approaches. And I'm going to provide you with some of these results in terms of accuracy. This is just one approach to presenting the accuracy of the model. And most of you are familiar with this, is an AUROC curve. On the x-axis is 1 minus specificity. On the y-axis, sensitivity. A perfect test has an AUROC curve of 1, and that of as good as a coin flick is 0.5. And our prediction models suggested a relatively good accuracy of at a 1 year outcome of 0.78, and then of 3 years of 0.76. Now we said, okay, well, if we can approach this in that methodological, with this methodological approach in that data set, could we actually do it where we actually want to establish this algorithm, which is within the VA? I'm going to generalize the population. We had all the data available to us. And so can we use the same data within the VA, which, as some of you know, has the oldest electronic medical record in the system in the world since the 80s? And can we predict who will go and progress to cirrhosis? In this particular case, we internally validated it and then predicted cirrhosis at 1 year, 3 years, and 5 years. The patient demographics here, 72,683 patients, much more than the clinical trial. Again, people might argue about the biases and the cohort, but again, we were trying to deploy this within the VA specifically. Age, much older, predominantly male, as you know, in the VA. And 53% Caucasian white. And this is, again, not something I want to go into detail about other than to show you that the AURCs were quite good here. We also provided some additional performance metrics that are extremely important to relate to those using it, including sensitivity, specificity, positive predictive value, negative predictive value, and then also highlighted some of the additional approaches that we used in terms of analysis. Now, why is this different than the traditional approaches that we use? Well, there's the population health approach versus the precision health approach. Again, population level where you say, okay, I'm going to go and identify a population and try and treat all of them versus being a little bit more patient level driven, especially when resources are limited. It's untargeted when you're doing it at a population level, but more targeted when you're trying to do it at a more precision health level. At a population health level, you don't need much data other than knowing, okay, well, this population has hepatitis C, we want to do it in an untargeted strategy. But in a more precision health approach, you need more of that granular patient data. The population health approach is potentially more scalable because if all you need is that one data point, then you just have to figure out how to do the implementation and deployment and the many practice and conceptual frameworks of doing that. But in the precision health approach, it needs a data infrastructure, and then the hope is that you can make that more scalable. And then the economics of this is that, in limited resource settings, is a population health approach really that effective versus really in a more precision health approach, you can optimize for targeted health and value for patients and providers. And again, we'd love to entertain some questions and thoughts around this. Now, when we think about the global context, are there ways to leverage data in a more global setting? Now, COVID-19 has been an exemplar for us about how global problems need global solutions. And I would argue that in the last 2 years, people have looked at graphs and charts more so than ever before and are beginning to understand the value and needs for this kind of information. But we also have to think about how we traditionally think about innovation. And we always think about innovation coming from high-income countries to low-middle-income countries. And this is sort of the traditional pathway of innovation. And one example of that pathway in the context of hepatitis C is the University of New Mexico's Health Sciences program around Project ECHO, where they have a hub and spoke model of care, where they try and deliver specialty care to rural settings where there are no specialists, and using data, telemedicine, and those innovative strategies that have now actually expanded globally, even to Africa. But we also have to think about reverse innovation, right? What is it that we can learn from the rest of the world that we would benefit from? One of the examples I'd like to highlight from this is the kangaroo mother of care model that some of you may be familiar with. The kangaroo mother of care is when preterm or low birth weight children can't regulate their temperature. And that's why we invented the incubator. But what we can show is that the human body is as good of an incubator, if not better, right? And the advantages of the kangaroo mother of care model compared to the incubator is there's a reduction in mortality, reduction in infections, maintaining of normal temperatures. And as we're trying to deploy our initiatives around care at home, the Cleveland Clinic and Columbia are already doing this kind of strategies in order to help maximize on innovation in other countries. But I argue that we should be doing this in a more reciprocal way. Reciprocal innovation, I think, is the way forward. And that, in some countries, there's even been leapfrogging in technology, particularly in Africa, where they went from having phones at home to moving to digital devices with a huge penetration of the digital phone market. And also, adding to that the financial innovation where M-Pesa is the first mobile-based cash transfer system in the world that was commercially viable for those that actually did not have access to banks or had no banks at all. And this has been deployed. And it's hard to even explain how much of a penetration that's been in Africa. So how can we use data in better ways? And how can we use the state-of-the-art data analytics and emerging technologies to rapidly advance our care options? As such, there was a few years ago, this was 2020, the University of Michigan Center of Global Health and Equity and the Aga Khan University, a global university that has health systems and universities in Kenya, Uganda, Tanzania, Afghanistan, and Pakistan, decided to come together and say, how can we work together in order to maximize the use of data? The Aga Khan University actually sees 7 million patients a year through their variety of health systems, but more importantly, have satellite clinics in rural areas throughout Africa and Pakistan. And the mission and the vision of the Center of Global Health Equity and the Aga Khan University was to improve health and well-being for our global community while leveraging data science initiatives. To create this two-way learning environment, this reciprocal innovation environment, to transform data science in global health. And we're lucky to partner with Aga Khan University because it was very timely. It was just that at that time that the NIH had a funding announcement around harnessing data science for health discovery and innovation in Africa. This was actually a $100 million funding announcement around 4 pillars. The first pillar was around developing research hubs. These research hubs would cater to not only the aggregation of data, but using data analysis, but then more importantly, developing 2 contextual projects or programs where there was felt to be a critical need for health. And I'll tell you a little bit more about that in an example. They wanted to also create data science training programs, which made sense in the context of what they were trying to fund, making sure that there were programs around the ethical, legal, social implications of data, and then a coordinating center to help facilitate some of these pillars. So we were lucky to apply for this project and actually received funding through this mechanism through the Aga Khan University with my co-PI Amina Abu Bakr, as you see is represented in this picture here. And the title of this project, or this successfully funded grant, was Utilizing Health Information for Meaningful Impact in East Africa Through Data Science. Uzima DS, I have to give credit to my program manager here who does not speak Swahili, but came up with that. Uzima means well-being and health. And again, this was something that we were fortunate to receive because of our collaboration with a global partner. And the project framework was to try and acquire data, different kinds of data. In fact, data that sometimes we don't even have in the United States. Surveillance data, social determinants of health data, climate and environment, this mobile penetration of data, of cell phone data, and then take other data that's more commonly used in the United States, including observational data, clinical trial data, EHR data, and then really apply artificial intelligence, machine learning algorithms to that to really allow us to help with risk prediction, outcome prediction, pattern recognition, but then ultimately find ways to deploy them and disseminate them into an environment, not only from an operational standpoint, but also from a personalized care standpoint. This is a framework, another version of the framework specifically around Uzima. And really we wanted to start at the top. Sometimes when we create prediction models, we're doing it because we have the data accessible to us, but are we really engaging those stakeholders that are going to be using it? And so we want to be very conscientious of that and involved the Clinton Health Access Initiative, the business program here at the University of Michigan, the Ministry of Health, the Aga Khan Foundation, and community leaders in saying, how do we make this something that's easily disseminated, sustainable for impact? And then one of the other cores that we created was around the data and method score, which is exemplified by data aggregation and data analysis. The administrative core that helps with the hurdles of the day-to-day activities of the research, and then focused on 2 primary research projects that again came from our African partners. One is around maternal, newborn, and child health, and one was around mental health in adolescents and young adults. And to provide you a little bit more specificity around that project too, one of those aims in there was to say, can we use Fitbits and mobile devices among healthcare workers and collect that information to predict the risk of suicide and depression, a key issue that's ongoing in Africa, let alone the rest of the world. This was emulated from Dr. Srijan Sen's project that's here around the intern health study, where first-year physicians coming out from their medical school have been given Fitbits and mobile devices to track passive data in order to make those predictions. So the future of data science, like we've talked about, is here, but the question is how best to maximize this. I'm coming at you from a sort of a different angle, mostly from the research standpoint, and how do we make the biggest impact by using the teams that are around us, and I think that's essential. Ehail is such a program that we've developed the eHealth and Artificial Intelligence program or initiative. This initiative was launched in May of 2021 as a strategic initiative between Michigan Medicine and the College of Engineering. It recognized that there's talented and enthusiastic faculty at the intersection of health and AI, and how could we leverage that talent? All the faculty traditionally at this large institution are fragmented across these different schools, and how do we bring these domain experts together, really with the mission to make the University of Michigan a premier hub for e-health and artificial intelligence? And we'll propose to do this primarily by building and fostering collaborations across campus, a big focus on grant development where we're actually trying to develop new innovative methodologies, which is primarily the emphasis and the research portfolio that we're working on. And then creating a shared resource for others to acknowledge and to understand and to use. And highlighted below are a number of the conveners and our staff that have been instrumental in making this initiative a success. As you can see, there's representation from the College of Engineering, Michigan Medicine, LSA. And within the first year of this initiative, I want to highlight 3 grants that have been successfully funded through the engagement in this program. One is from Dr. Weens here and Dr. Giordani. It's through NSF, the Smarter Connected Health funding module around tracking or tackling progressive disease using and learning longitudinal observational clinical data in the presence of noise and confounding. I talked to you a little bit about the Uzima grant. This was an NIH-funded Fogarty-sponsored grant for $6.5 million. And then one from Dr. Dorsch and Dr. Brahmaji Nilamuthu, a just-in-time adaptive mobile application intervention to reduce sodium intake and blood pressure in hypertensive patients. This is an NIH R61, R33, about $800,000 a year. So I want to thank you for your attention, and I have contact information for Ehail. Henrique, I believe, is here too if you want to talk to her. And then the Center of Global Health Equity, Christina Rice, if you have any other further questions around some of these programs. Thank you so much.
I believe we have about 5 minutes for questions, if anybody has any questions for Dr. Waljee. Any cards in the air? Anything in our chat function for questions?
Karandeep?
Karandeep, I'll just come to you.
Yeah, my question is your thoughts around digital divide. I know this is brought up as an issue. Is it a tractable issue? Is it an addressable issue? Is it a society issue or is it a technical issue? I'd love to hear your thoughts.
Yeah, I've been thinking a lot about some of those biases that are introduced. And, even as humans, we have those biases. And those biases are represented in how we treat patients. And I'm not saying that this is an arguable defense of anything, but what I am saying is that these are some things that we need to be cognizant about. We need to be very transparent in the development of our prediction models, where we think they work and they don't work. And again, I think it's really important to recognize that, where you're trying to use these methodological approaches and these devices as, at least in this current form, as a supplement, as a decision support system to your usual care. And I feel like that's really, really important, where, as we just talked about, the man and the machine, or the human and the machine, is much more powerful than individually alone.
Great, thank you.